Hello, this is Elizabeth, and I will be presenting on this section on detecting tuberculosis in patients and identifying the bacteria in the lab. So the patient's diagnosis is based on several factors. Typically, if a patient has active tuberculosis, they're going to be experiencing some signs and symptoms that are pretty indicative of pulmonary disease. This is going to include a long-lasting cough that lasts more than 3 weeks, some unexplained weight loss, night sweats, chills, fever, weakness, things like that. Pretty intense respiratory illness. However, that is just for an active TB infection. So if a patient has latent TB, that diagnosis may be a little bit harder to come by. As a result, we'll typically look at laboratory tests, which detects an immune response to TB antigens. And there's two forms. There's the skin test and a blood test. Now, if a patient tests positive for a skin test, they'll typically run confirmatory tests with chest x-rays or radiologic tests. This is particularly the case for patients who don't have symptoms. So if their skin test for screening comes back positive, but they don't have symptoms, they do a chest x-ray and they do find evidence of latent TB, then they'll be put on therapy. And a big piece of a TB diagnosis is based on that patient's social history, their medical history, and their travel history. So populations that are living in TB endemic areas or visiting TB endemic areas are at a higher risk. Anyone that has come in contact with an infected person, and their vaccine history also plays a key role because that can cause false positive skin screening tests even though they don't have the disease. Anyone also who has been in contact with infected persons or has been living in close quarters, been institutionalized, is also at a higher risk. So that includes people in prisons, people in residential communities, people living in dorms. So that is a key piece of information that doctors need to get when they're trying to diagnose tuberculosis. But because we are in CLS, we're going to focus on the laboratory tests that are done. So the main screening test is the Mantoux skin test. This involves an injection of purified protein derivative. This is an antigen directly from the Mycobacterium tuberculosis bacteria that is injected under the skin, and the patient is told to return after about 48 to 72 hours. And the reaction will show a red raised bump if they have a latent or active TB infection. This is the body's immune response to being sensitized to that antigen in the past. So if they have been infected with TB before, or if they have a latent infection, their body will respond quickly to the antigen that's being injected, and they will produce a delayed hypersensitivity reaction. This is a type 4 hypersensitivity reaction. So this is, again, the body's immune response to the antigen, and this is great for testing, detecting latent infection, active infection. However, if anyone has received the BCG vaccine, which is typically given in foreign countries outside the US, this skin test will always come up positive. So it cannot be used for people who have been given the BCG vaccine because it will be inaccurate. It will just always show a positive reaction. So an alternative is a blood test. These tests measure the production of interferon gamma by sample T cells after interacting with Mycobacterium tuberculosis antigen in vitro. So both of these tests measure interferon gamma, but they do so in two different ways. The main one that's done is the QuantiFERON TB Gold Plus, and the other one is the TB Spot TB. Again, they both measure the production of interferon gamma by the patient's T cells, but they just do so in a different manner. So first, I'll talk about the QuantiFERON TB Gold Plus test. To collect the sample, blood is collected into 4 separate tubes. The first is a purple or the mitogen tube. This measures the patient's nonspecific immune response. There's then a gray or nil tube, which is going to measure the background interferon gamma that the patient produces. And these are sort of used as controls. The two antigen tubes, yellow is the antigen 1 tube. This is going to measure the interferon gamma produced by CD4 cells that have been sensitized by M. tuberculosis, if they have been sensitized. And then the green tube, or the antigen 2 tube, is going to measure the interferon gamma produced by both CD8 and CD4 cells that have been previously sensitized by M. tuberculosis. The reason two antigen tubes are used is because it has a greater sensitivity to whether the patient has a latent disease or an active infection. And they've found that by using both of these different combinations of antigens, they can more accurately and quickly diagnose TB, whether it's latent or active. So in order to detect this interferon gamma, the samples are mixed, the tubes are mixed. The goal of this is to dissolve the antigen that's coated on the sides of the tube and combine that with the patient's sample. Those tubes are then incubated at room temperature, mixed again, and incubated then again at 37 degrees Celsius. Then an ELISA is performed. So anti-interferon gamma on a solid phase particle is going to bind with any interferon gamma that has been released in the patient's serum. And then a reagent is added. So it's anti-interferon gamma and conjugate. The starter reagent is added, and then a reaction occurs. The chemiluminescence or detection is measured, and then this can be done in an automated machine or manually to quantitatively determine the amount of interferon gamma that the patient sample produces. And UNC Labs uses an automated machine called the Liaison, but then they also have manual ELISA as well. Here's a table that's used to determine the results of the QuantiFERON Gold. It's a combination of equations, essentially, but you're going to look at the nil tube, the mitogen tube, and each TB antigen tubes to determine if infection is likely or not likely. So similarly, the TB spot TB test will again measure the interferon gamma produced by patients' white blood cells. However, it is done a little bit differently. The blood is collected into a single tube, and white blood cells are collected from the buffy coat. Those cells are washed, isolated, and enumerated, and then a known standardized cell suspension is going to be created. The specified number of cells are going to be added to plates that are coated with TB antigens. And then if the patient's white blood cells have already been sensitized by TB, aka they have had a latent infection or they have an active infection, they're going to produce interferon gamma. And then again, anti-interferon gamma antibodies are added. A secondary antibody labeled with enzyme is going to bind to that. And then the reaction reagent is added. As a result, spots will be produced where those interferon gamma was released around those white blood cells, and those spots are going to be enumerated. So patients who have infection are going to have more spots, and the interferon gamma measured is going to indicate whether or not they have a latent or active infection. And here's a little visual of how those results are interpreted as well. So again, measuring interferon gamma, just doing so a little bit differently. The first using ELISA with chemiluminescence, and this one using quantitative spots per well. So blood tests and skin tests are used to detect TB disease in patients. But when it comes to identifying the actual organism in the lab, we do different processes. We use the acid-fast bacilli smear and sample culture. Typically, this is taken from a sputum sample. Usually, this is going to be patients who have pulmonary illness and symptoms. So this can be a coughed up sputum sample, a BAL, which is bronchoalveolar lavage, or a thoracentesis. So again, just getting that lung sample. When you get that sample, they are going to stain it using an acid-fast AFB smear, and M. tuberculosis is going to stain red. So that is pretty indicative of TB. If they're going to grow the culture, it does take a while. It takes 4 to 14 days in broth or 3 to 6 weeks in solid media. So that's part of why TB isn't actually diagnosed using culture alone, because that patient is going to be experiencing symptoms and having to wait a long time before they can get any sort of growth in the lab. PCR can also be used to definitively determine the organism in lab. This uses probes to specifically detect the DNA or RNA sequences that are present in M. tuberculosis, and can also detect mutations associated with drug-resistant strains. PCR is much faster than culture growth. And PCR is super helpful, especially in the era of TB-resistant strains and finding the treatments that are going to work best for patients. So these are the two different methods used in the laboratory to identify the organism, and both culture and molecular methods are recommended for confirming TB identity, and they're both used in antimicrobial susceptibility testing. They're usually recommended to be used together and not just in isolation. So that is how we diagnose patients and identify the organism in the lab.